Hi, my name is Chau Dang. I'm a medical oncologist at Memorial Sloan-Kettering in New York, and I treat breast cancer patients. And this year I've had the pleasure to be at the Female Cancer Symposium in Salvador, Brazil. And it was such an honor to be asked to come speak on several topics. And I started out with the first day speaking on if there's a role in using anthracycline-based treatment for patients with breast cancer. And I think with the emergence of many genomic signatures, we will have guidance on which patients can have chemotherapy aborted to start. But today, burden of disease still matter, meaning the volume disease such as high lymph node positive disease of 4 or more. Certainly that is where I believe that the value of anthracycline is still there based on the ABC study, and I think we await the result of the RxPonder trial in patients with hormone receptor positive 1 to 3 positive nodes, where patients were randomized to chemo or no chemotherapy, and most of the chemo options were anthracyclines, and we'll be able to see whether many of these patients can have chemotherapy aborted. And the second day was a very interesting day as well, where my first talk was to talk on the optimization of treating patients with HER2 positive breast cancer in an adjuvant, neoadjuvant setting, and to give the background of trastuzumab, which has completely changed the prognosis of our patients, not only in the metastatic setting, but early setting, and in the adjuvant setting, where with a long-term follow-up of over 10 years, that patients treated with trastuzumab chemotherapy are doing very well with excellent disease-free and overall survival. And recently, in the last several years, pertuzumab was approved in the neoadjuvant setting for patients with larger tumor burden, stage 2, 3, and it was found to double the pathologic complete response rate when added to trastuzumab and standard chemotherapy versus trastuzumab chemotherapy alone. So for several years, patients were being given pertuzumab-based treatment to downstage their breast and axilla, and very recently, last year, patients with stage 2, 3, and some stage 1 were enrolled into the Affinity study, where pertuzumab-based treatment was given for the course of the year. And we really saw that although there was an improvement in 4-year disease-free survival, the absolute gain was quite small in all patient populations. And when looking at the subset where the benefit was most significant, it was in patients with node-positive disease. So this, to me, is certainly somewhat consistent with the Cleopatra data, where pertuzumab added to trastuzumab was found to improve outcomes, including survival, for patients with metastatic disease. They had high burden disease. Now, in the adjuvant setting, for patients with node-positive disease, meaning high burden disease, that is where we saw much of the gain. So, so certainly there's a role for pertuzumab. And I spoke a little bit on neratinib from the ExoNet population, and spoke on lesser chemotherapy with a taxane trastuzumab for patients with lower burden disease, such as with paclitaxel and trastuzumab. And then lastly, my last talk was on sequencing of optimal anti-HER2 therapy for patients with metastatic disease. And again, over the last 20 years, we completely altered the prognosis and outcomes of patients because of the advent of all these incredible targeted agents, starting with trastuzumab, and in my mind, it remains to be still the best antibody today. And it was approved in 1998 with chemotherapy for patients with metastatic disease. And it took many years, almost 15 years later, for us to report the data on pertuzumab added to trastuzumab, where we saw an improvement in progression-free, but importantly, survival. So today, for frontline treatment, it is a taxane with dual antibody therapy. And afterwards, upon progression, certainly in the antibody-drug conjugate, T-DM1 is still the current standard for second line. In the third line setting beyond, there are so many options for our patients. And we're working hard to study more novel therapies for patients added to our current anti-HER2 therapy, combining anti-HER2 with immunotherapy, as well as CDK4/6 inhibitors. And lastly, I want to mention a word on patients with brain mets. Although our patients are doing very well and surviving metastatic HER2 positive breast cancer, unfortunately, there's a high percentage of these patients who will have progression disease in the brain. And a lot of research is ongoing to develop drugs that are effective for patients with brain metastases. This is clearly an unmet need, and we look forward to the report of ongoing research and continue to improve the outcomes of our patients. So it was a real pleasure to be at the symposium, and we ended today with a time with our colleagues to discuss challenging cases. I completely enjoyed talking about treatment options and management in difficult cases, and I've learned a lot from our colleagues here in Brazil, and I hope to come back another time. Thank you.